good afternoon, good evening, good morning to everyone, as we have people coming from all around the world. My name is Claudia Fernandez de Cordova. I'm a research assistant at the UCL Warning Center, and I'll be your host today. Before starting, I'd like to provide a few housekeeping tips. The first one is for all the people who are coming in, if you could introduce yourself in the chat. You can also share links and resources or make any comments. Not any, but you can make comments. Also, if you have any questions to our panel members, please use the Q&A. Panelists, please make sure your microphone and your camera is muted when you're not speaking. And any security breaches will be dealt rapidly by Giuseppe, Karina, or I. If you want to share anything on social media, our Twitter hashtag is UCLWRC, Warning Research Center. And please feel free to log in and log out during the tea break. So here we are. So first, we're going to start by the presentation of Karina Furley, which is the director of the UCL Warning Research Center and lecturer in Science and Technology Studies, and will be welcoming and explaining a bit more about the Warning Center.
Great, thank you very much, everyone, and thank you so much for joining us today. I shall just pop a presentation up just to give you a brief overview of who we are. So we are the UCL Warning Research Centre, and we are delighted to be hosting this seminar today. As you may be aware, there was certainly for our delegates in the UK, there was been some fantastic lecture yesterday, the Richard Dembledy lecture by Professor Dame Sarah Gilbert, and also some really great news articles that have really highlighted the importance of us thinking about the next pandemic. So the idea that we were warned about the COVID-19, not specifically for COVID-19, but we did have warnings, and we need to be prepared for the next variant of COVID, and of course the next pandemic. So we really need to be, and of course the whole global community is really thinking about how can we prepare. And as a warning centre, we really wanted to take this opportunity to discuss how warnings are such a critical component of that. So we as a warning centre are the first dedicated warning centre that looks at both natural and human-made hazards. And what we want to do is bring together expertise from all around the world and stakeholders from a wide range of groups, not just academia, but all sorts of different government agencies, different disciplines, and also those communities that are affected by a natural or human-made hazard. And we want to cut across all of the vulnerabilities, hazards and threats to really explore how warnings work, what can we learn from nuclear events that might be useful for a pandemic? What can we learn from pandemics that might be useful for volcanoes when we're thinking about warnings? And so by creating this space and this dialogue in this community, we really hope that we will be able to reframe warnings, really think about how we can make them stronger and more effective in the future. So we are globally unique. We have 25 core members from across University College London. We also have 27 affiliates who are world-leading experts in warnings from around the world. And we have a number of goals all around creating that community, providing teaching excellence, training, public engagement and research expertise around warnings. And what we really want to do is be able to put warnings on the agenda. So please do check out our website, have a look at what we're up to. We have social media on Twitter, LinkedIn, Facebook and YouTube. We like to share news about warnings. We're running a number of different events and a series that's starting today and going forward to next year. And so please do keep in touch with us, and we'd love to hear from you about what you might want to hear about in relation to warnings. So welcome. Thank you so much for being here, and I'll pass back now to Claudia.
Thank you so much for that, Karina. Now for plenary, let me introduce Dr. David Navarro, CBE, the Strategic Director of Foresd, the Co-Director of the Institute of Global Health Innovation at Imperial College of London, the Special Envoy of WHO Director General on COVID-19, and Senior Advisor of the Food System Summit Dialogue. It's a pleasure to have you here.
Gorgeous. Thank you very much indeed, Claudia. And hello, everybody. I'm here really with a lot of friends, and that makes me always feel inspired. But I have to be honest, I've been working on zoonotic diseases and pandemic preparedness since 2005. I was involved a lot in avian influenza, H5N1 in Southeast Asia. Also was involved in a human influenza pandemic, H1N1 in 2009, and then Ebola in West Africa in 2014, and then a series of outbreaks in Latin America in 2016. And haven't done very well, because quite honestly, if the various warnings that I'd been offering, and colleagues also who are in this seminar had been offering, if our warnings had been heeded, there would have been a series of mechanisms established internationally, as well as in some nations, that would greatly improve the capacity of different sectors to deal with threats like COVID-19. And I believe that the quality of the global response would have been an awful lot better to global 19. We warned, but we were not heard. And so in this opening presentation, I want to focus on what warnings are being heeded, what warnings are not being heeded, and what on earth we ought to do about it. I told you that we were working on pandemic preparedness linked to bird flu in 2005. And it was really very interesting. The leaders of all the countries in Southeast Asia through ASEAN came together in the month of September 2005 and said to the United Nations Secretary General, we're really worried. Bird flu is affecting birds in our region. It's leading to enormous numbers of poultry deaths. And we're worried that it's going to jump into humans and cause another influenza pandemic as bad as 1918. And so they asked the Secretary General of the United Nations to himself get involved in the need to prepare for pandemics. And that led to me being transferred from a role I had in the World Health Organization to working in New York as the first United Nations system influenza coordinator to help prepare for pandemics. But it was very hard to maintain interest in pandemic preparedness, especially during the period between 2005 and 2014, when I was moved on to something else. Yes, UN organizations got involved because their economists said, you prepare and then it reduces the cost of the pandemic when it happens. They're specialists in public health, veterinary medicine, or environmental health, said, yes, we prepare because that then helps us to shape the kind of services we want to set up. And inside the actual incident management center that linked together the World Health Organization and involved other global organizations, a real powerful capacity to respond to signals of possible spillover of pathogens from animals to humans was set up and was running. And you know, that center receives something in the region of 3,000 signals a month, 300 of which are thought to be serious enough to require screening, and 30 a month are actually investigated. That's 30 a month. That's 360 a year. That's 360 events involving spillover actually investigated. And WHO and other parts of the UN system make the point that by having this capacity to pick up early and respond to signals of spillover, we within the international system are helping to reduce the risk of new pandemic causing agents from getting out. The problem is not so much early warning for the earliest detection. By and large, that can be done well by networks of technical experts. There's things called the Global Outbreak Alert and Response Network that do that. But it gets more difficult when you are in a situation where a large and really serious spillover event is occurring, and a major outbreak like West Africa, Ebola 2014, or more recent Democratic Republic of Congo, Ebola's, when these kinds of bigger events happen, then it becomes harder because you're having to try to get whole of government to come together and work to reduce the threat. So I thought, as I finish, what I'd like to do is to offer some observations, not so much on what we need to do with the majority of signals that can be dealt with quite quickly. A small number of people reviewing data, perhaps doing a field visit, usually you can pick it up, but it's that very small number of very serious potential pandemic pathogens that emerge and that need to be dealt with. What can we do now to institute in society the capacity to respond to these early warnings when it's early warning of a major and serious problem, like what we've got with COVID-19? Here are my suggestions. Number one, got to bring together people who work on animal health, environmental health, and human health, and have them working as a single professional group. I like the One Health approach. However, it's not proved easy to implement One Health in many countries. There are structural challenges because the power structures in human health, in veterinary health, and environmental health are very, very different. There are cultural challenges as well. The value systems within which these different professions operate are not the same. And there are huge budgetary challenges. Human health is far better funded than veterinary health, and veterinary health is far better funded than environmental health. Therefore, I would like to say that to improve the response to early warning, there needs to be attention to the challenges of integrating the different implementation structures in human health, animal health, and environmental health. Secondly, remember that in each of these disciplines, we have people, usually technical people, usually very committed technical people. And yet they're trained separately and they work separately. It's only a very rare government that actually makes the effort to bring these people together for joint training or joint exercises. So I would like to propose that in veterinary medicine, in environmental health, and in human public health, we institute joint training and shared assignments for human, animal, and environmental health professionals as a rule. Every human health professional should have a period being a vet. Every vet should have a period in public health. And vets and human public health should have time doing environmental health, to understand the pulls and the pushes, the politics and the challenges in the different areas. Number three, we've got to learn to make decisions and to implement actions during what I call peacetime, between individual major zoonotic events, whether it's Ebola, whether it's HIV, whether it's COVID, whatever else. Between these events, everybody forgets about them. Budgets get trimmed, activities get slimmed, and the impetus to work at the interfaces between professional disciplines just drops. And that means that during the period between outbreaks, there's insufficient investment in the working procedures that will enable different disciplinary groups to respond to warnings and work together. So let's take advantage of the peacetime periods between crisis moments and actually build a mindset of systems thinking and systems leadership that brings these different developments, these different professional groups together. And last point, that before finishing, I'm not going to give up, although I've been working in this area since 2005. And although we have worked for ages to try to get early warning, we've worked time and time again to reform the international system so it responds better to outbreaks and pandemics. We have worked tirelessly on training and tirelessly on trying to finance standing capacity between pandemics and outbreaks for continued working. And we haven't so far been able to get these taken seriously. I'm hopeful that as we go through COVID, and I don't think we're going to have an end of COVID for a long time to come. So as we go through COVID, let's also focus on the capacities that need to be built so that we work on an interconnected approach to all living systems in the way in which we operate. And I undertake in front of all of you as much as I can to try to maintain that energy as we continue with COVID and as we anticipate further pandemics and work, as I see it, on an intergovernmental treaty for pandemic management for the next time. So thank you very much indeed. Lots of work to do, lots to learn from the past, and what a brilliant initiative from colleagues who put this event together. Thank you.
Thank you so much for your time, and thank you for these amazing words. I'm particularly amazed by the idea of breaking One Health to think about it in one single component, and the idea that most of the times the graphs are separated between three, while we actually should be thinking about these issues as one. I think you could have not said it in a better way. So thank you so much. I'm gonna go and look at the questions. The first questions. If we're working on research in this area, how can we stay connected or for opportunities of funding calls? Well, maybe let's go with the second one and then the first one. To figure out a warning system, should it be necessary to build inventories of records for small infectious diseases for detailed geographic areas with an acceptable historical window and associating other social and natural variables? What is your take?
Thank you very much, Mario. Actually, there have been some really interesting pieces of work, particularly during the period 2005 through to 2015, on trying to identify areas where there's a high likelihood of the spillover of pathogens from animals or from environmental vectors into the human population, and indeed vice versa. More recently, within the context of the National Academy of Sciences Forum on Microbial Threats, and that Forum on Microbial Threats is the name of the group within the National Academy of Sciences working on these issues, they have started to put together an analysis of the particular kinds of social and natural variables that can be associated with spillover events taking place. They've gone further and they've identified particular geographical areas where the risk of spillover associated with these social and natural variables is highly likely. I mean, the person who's the leader of the Forum on Microbial Threats is called Peter Daszak, and he's been leading this work, but there's a whole community of leaders who've been working in this area, and they can be accessed through looking at the different people who are involved in One Health. And I would always argue, and that's going to be my answer to the other question that's come up, that it's really important to identify people who are really interested in a subject area and who are working at the margins between that particular discipline and other disciplines. And you keep sort of, once you find them, you can hold on to them. I mean, it's really invidious to mention names, but I have always associated John Mackenzie with One Health. Also, Kate Dewey, spelled C-A-T-E-D-E-W-E-Y, of University of Guelph, G-U-E-L-P-H. She's also been a very strong person on this. And I'm very, very keen. If you want to stay in touch with me, I can always be a correspondent because I'm in touch with most of the people who are really interested in One Health around the world, and I can try to provide some kind of contact. I know that it's unsatisfactory, but actually most of the people who are working on spillover know each other, and that can actually be quite helpful because they carry a huge amount of information in their heads, and it's worth trying to get in touch with them and be in touch with them. Now, in terms of opportunities for research and funding calls, where can one really get the best help? Well, I used to say, go to the Wellcome Trust, because the Wellcome Trust was particularly involved in One Health and the One Health movement. And we might get a point of view on that from others who are involved in this seminar. But there isn't, at the moment, at least for me, a single funding body who has become the natural go-to funder or for this crossover area of animal, human, and environmental health. So what I would suggest is, as far as possible, please keep in touch with something called the Tripartite. This is a collection of WHO, World Health Organization, FAO, the Food and Agriculture Organization, and OIE, the International Organization of Epizooites. That is 3 organizations that have come together to work on these issues. They're trying to be joined by the UN Environment Programme. It's not yet fixed. And that will then become the UN center point. And I would strongly suggest staying in touch with them through whatever means you can. And they will be, I think, the most likely to be able to announce funding calls. But I can't give a better answer than that. Back to you.
Thank you so much, David. I got another question, direct question, which is, how can we use warnings used for other natural disasters, natural hazards, such as floods, volcanoes, or earthquakes, and implement them for health?
When I was working in the office of the UN Secretary General, that's not meant to show off, that's just the job that I did really strongly for the period 2016-2017. I was trying to find a way to bring early warnings around diseases, particularly spillovers, into the language of crisis anticipation and management, of dealing with humanitarian crises like natural disasters or conflicts or climate-related events. It doesn't work easily. The people who are involved in dealing with spillovers are veterinary scientists, are environmental health scientists, are human public health scientists. They're not the same culturally as the people who work on natural disaster responses, who deal with earthquakes, who deal with floods, who deal with war, who deal with bad violence. You could say, well, can't you fix it? Can't you squeeze them together? But something that I've learned over the years is that the culture of a group of people really matters. And I haven't found an easy way in my professional life to get the public health people to be comfortable about turning up regularly to meetings where the natural resources people talk about warnings of earthquakes or tsunamis, or where the conflict people talk about expectations of physical conflict and war. We got a bit better when I was at WHO and the Director General set up an outfit called Health Action on Crisis. There was the beginnings of the coming together of people working on human health and people working on disasters. And I think probably within the UN system, it's about as good as it's been for a long time. And so I would suggest do connect always with the crisis people in the UN system. They're connected through a group of NGOs and others through the Interagency Standing Committee, and they're connected through the Office for the Coordination of Humanitarian Affairs, which is the acronym that's pronounced OCHA, which deals with the different parts of the UN. And get in there and ask, you know, where is the space where we can talk about disease threats in all this work? Are you running with an early warning on disease threats? They'll probably say that's handled by WHO, or that's handled by WHO with the FAO and the OIE. But we ought to make them all joined up together better, because there's not a lot of people who work on early warning. There's not a good listening point in the world for picking up on early warning and then acting quickly with early money that makes a huge difference. Because if you act 3 months early in a crisis response, I can promise you that the cost is sometimes 10, perhaps even 100 times less than if you wait 3 months. So there's a huge value of responding to early warnings, but the culture is not properly drilled in. And I'll tell you why. It's because so often you issue the warning and nobody acts. You say there are locusts gathering and there's going to be another massive locust movement across the Sahel or across the Horn of Africa. And then 3 months later, people wake up and they start seeing masses of vegetation being destroyed. It's really hard to get what responses to early warning. And so I think the best thing that we can all do, particularly folk like me who've been around for a bit, is work on who's listening for the warnings, who's going to act when the warnings come, because goodness me, you save a lot of money. Always, always see it again and again. Slow responses means a lot more suffering and a lot more budget being spent.
Thank you so much, David. I'm conscious of the time, but again, on behalf of the all UCL Warning Research Center, thank you for your presentation and thank you for answering all the questions. It's been enlightened, and well, we hope we can keep on collaborating in the future. Thank you.
And just a real shout out to Madeleine Thompson, absolute sterling, stellar, brilliant person. Lovely to be on the same panel as you, Madeleine.
We're very excited to have her here today also. Okay, we will be following with a presentation on the topic of the event. Let me share my screen. So in this first presentation, I'm going to be talking about bridging public and environmental health and building preventative warning systems. So first, here's an overview of the history of pandemics in the last 1,500 years. But I actually want you to look at and think about the last 40 years. One key study that was published by John Zeol in 2008 showcased that since the 1980s, while cases per outbreak have been falling, the amount of emerging infectious diseases is rising in both diversity and frequency of outbreaks. What these findings seem to indicate is that while our ability to quickly respond and contain outbreaks of infectious diseases is improving, over time, human activities are also leading to an increasing rate of emerging infectious diseases. And most importantly, efforts to quickly mitigate infectious disease are not sufficient to compensate for the impact that ecological changes are having in their increased emergence. Since then, numerous studies have showcased the rise of emerging infectious diseases, even after having accounting for reporting bias. That is accounting for the fact that over time, there might be more reporting and detection of diseases that before might not have been flagged. Another key finding is that 3 out of 4 new infectious diseases are zoonotic. A zoonosis is a disease which is transmitted across species from animals to humans. And in the last 10 years, actually, zoonotic diseases have tripled. So even though COVID-19 might seem for us an isolated event, it's actually part of a much, much bigger trend. So now let's look at what are the drivers of zoonotic diseases. Very simply put, everything that changes the transmission pathways between humans and animals is likely to be a driver of zoonotic spillover. However, looking more closely at ecological studies, we can see that the main driver of infectious diseases and zoonotic diseases is land use change and ecosystem changes. Those are primarily driven by agricultural intensification and livestock production. So what is the role of warning systems? When you think about warning system, most people think about an alert or a fire alarm, but warning systems are much, much more complex than that. They encompass hazard monitoring, disaster risk assessment, communication, and all types of preparedness, prevention, and response activities. So you have to remember one thing about warning systems, let that be integration. And integration is key also within health hazards. To maximize the efficiency of our responses, we need a coordinated action plan. So what are the key elements that are involved in responding to health threats? Here, I've divided them into 5 different categories. The first one is prevention. It's actually tackling the factors prior to the emerging infectious diseases that are leading to this emergence. Then we have preparedness. How can we build a better healthcare system? How can we prepare our healthcare system to cope with health emergencies? Then we have prediction and early warning, which is monitoring, detecting, and anticipating new outbreaks, as well as communicating those risks effectively. Then we have response, which are all the strategies which deal with diminishing the spread of the virus, such as non-pharmaceutical interventions like lockdown and protective personal equipment, but also vaccinations. Finally, we also have recovery. How can we build better systems based on the past lessons we have experienced? On the right, you have a disaster risk management cycle, which showcases you the traditional steps which are involved. In all these steps, warning systems are crucial. So here, I wanted to showcase a bit what are the priorities of our current warning systems. In which of those sections are they involved? One thing that becomes apparent when looking at warning systems at the international, national, and local level is that most of them are on the right side of the diagram. That is prediction and early warning and event response. So everything that deals with monitoring, detecting, and mitigating health risks. For example, Twitter tool or health map use informal data sets like social media to detect health events. We also have GeoSentinel, which tracks issues within travelers and makes reports. We have GORN, the Global Outbreak and Response Network, which previously David mentioned, which sends staff and resources to countries experiencing health emergencies. All of the systems that I've just mentioned existed prior to COVID-19. However, since the COVID-19 pandemic occurred, other warning systems have been created, such as the New Zealand COVID-19 alert levels, or the NHS local alerts, or the COVID-19 forecast hub. There's also organizations such as NGOs, Doctors with Africa, QAM, and Red Cross, which are involved in response. So overall, one thing that becomes clear is that most organizations and warning systems actually wait for outbreaks to occur before considering them as health hazards. We are missing warning systems which are focused on anticipation and prevention and all preparedness activities prior the spillover event. However, on a positive note, organizations such as the European Environment and Epidemiology Network are leading the way by integrating different types of data, such as health data, environmental data, climate data, and other types, to actually have a more holistic warning system. GLUES is also a great example, as David mentioned before. So here, let me use, this is a model of what a global early warning system could look like. This was actually made by one of our speakers, which will be speaking later on, John Drake. So what I want to emphasize is that in the first part of the model, which is focused on preventative management, we're actually missing all these activities prior to the emergence. That is completely missing. So when we think about at the beginning of the lecture, when I was telling you about the crucial role that ecological changes have, it seems as if, you know, our research and understanding of the problem is not truly aligned to how we're responding to it and the policies we are issuing. So why is that the case? So one reason why that is the case is that most systems available are actually designed by human health specialists, not veterinarians, and especially not ecologists. And this focus on public health actually shapes how we conceptualize the problem. So let me show you these two graphs. On the left, we have an ecological framework. On the right, a biomedical individualist framework. So what the biomedical individualist framework shows is that the disease, in this case, SARS-CoV-2, was created by animals either eating wildlife animals represented by the pangolin or coming into close contact with them, such as the bat. In contrast, the ecological framework expands this understanding to allow for ecological encroachment and climate change as factors which are changing the transmission pathways are now increasing the rise of infectious diseases. So even though this framework is very simple, it showcases how focusing on public health shapes how we conceptualize the problem and then consequently narrows the type of responses that we can take. So now let me talk to you about the future directions for warning system. The graph that I put on the left showcases three types of surveillance systems: A and B, traditional, and C, digital detection. So traditional disease detection is based on a simple association between the number of cases and a digital disease signal, which is issued. The second one actually acknowledges the drivers prior to the emergence of infectious diseases, but only once the disease has emerged and there's been an outbreak. So actually the detection is at the same point, which is showcased by the red dot. The third one actually is focused on monitoring the drivers, not the disease, the driver. So looking at what are the conditions which are suitable for the emergence of infectious diseases. And that would allow not only for potentially detecting outbreaks much earlier, as showcased by the orange point, but it could also help us build warning systems which address and respond to risk factors much before there's been a health threat, showcased by the purple one. So one key interdisciplinary framework is One Health. One Health, the goal of One Health is to create collaborative, intersectoral, and transdisciplinary approaches that recognize that human, animal, and environmental health are interdependent. In principle, this is a great framework. However, in practice, it has been sometimes limited by a focus into the direct and proximal causes of disease emergence. What I mean by that is wildlife animals or livestock. And the policies that are linked to One Health are often biosecurity strategies, such as putting in place physical barriers to separate livestock to wildlife, or surveillance to monitor the intersection between the wildlife animals and livestock. While these are essential to mitigate the spread of emerging infectious disease, they don't actually address the cumulative factors and structural factors that are increasing their emergence. Interdisciplinary frameworks need to go further than just having a multilateral understanding of the pathways of transmission, but they also need to account for the positive agency that humans and animals have. And it's fundamental that we don't only focus our efforts on controlling and separating the interface between these two, because this is neither feasible nor good. So now let me tell you a bit about a case study, which I think is always good to get to know a bit more about what I'm saying. So here the case study is Egypt in 2009. By fears of swine flu outbreak, there was a culling of 300,000 pigs. And these pigs actually were involved with the livelihoods of the Coptic Christian minorities, which used to manage a big part of carers' waste. Biosecurity strategies which put in place this culling failed to account for the positive agencies that animals had in human life. And a year after, Egypt was facing a huge urban waste problem. This is a very interesting story because it showcases how animals should not only be considered a source of contamination, but have a much more positive impact. So I want you to think about emerging infectious diseases as part of an integrated system in which the disruption of our ecosystems is a key component of that. That's why today we have an interdisciplinary panel, bringing experts that work across silos. We have Dr. Madeleine Thompson, expert on climate health sensitive interventions, Dr. Jan Samantha, which has led the work on environmental and climatic drivers of infectious disease transmission, and Dr. John Drake, which not only has created a model for a global early warning system, but is also an expert on the ecology of spillovers. So it's not only fundamental that we invest in prevention because it's good for human health and it's good for the planet, but even better, it's actually financially advantageous. Dobson studies showcases that the cost of preventing the next pandemic might be about 2% of the cost that we're currently paying for COVID-19. If we invest in things such as preventing deforestation, regulating wildlife trade, and the early detection and response. So when moving forward, in the same way that during 2004, 2005, the SARS pandemic pushed forward a momentum for change, we are in the same situation. We're in a key momentum for change in how we conceptualize and respond to health threats. This November, there was a health assembly to consider the creation of a new pandemic treaty on preparedness and response, and also the potential of reforming the international health regulations. If I could put forward one thought, is that we need to incentivize the collaboration between these three sectors. As David said, we need to think about them as one. And one way of doing that is by building driver-centric warning systems. Those are systems that are focused on the factors prior to the emergence of infectious outbreaks. These have a strong potential, and we need to redirect our efforts towards that. Thank you so much for coming today and hearing us all. So moving on, we'll have the next speaker is now Dr. John Drake. Dr. John Drake is the director of the Center for Ecology of Infectious Diseases. He's a distinguished research professor and is an associate dean for academic affairs and the graduate program faculty at Odum School of Ecology, the University of Georgia. Thank you so much for coming today. We're looking forward to seeing your presentation.
Thank you, Claudia, for the invitation. What I'd like to do first is introduce myself, the center that I work in, and one of our new initiatives, the Global Infectious Disease Intelligence Consortium. I'm Distinguished Research Professor of Ecology in the Odum School of Ecology. I was originally trained as a traditional muddy boots out in the field biologist, but over the last 15 years, I've concentrated my efforts on understanding the conditions that give rise to spillover and the dynamics of infectious diseases. COVID-19 is probably the most documented pandemic in history. Since December 30th of 2019, more than 700,000 articles, books, and other publications have been written about COVID-19. None of us, however, should have been surprised that COVID-19 in fact occurred. In January 2000, over 2 decades ago, the United States National Intelligence Council published The Global Infectious Disease Threat and Its Implications for the United States. This was one of the first important publications from the US intelligence community about infectious diseases as a non-traditional threat to the security of the US. This document followed a June 12, 1996 White House press release titled Addressing the Threat of Emerging Infectious Diseases that said that the national and international system of infectious disease surveillance, prevention, and response is inadequate to protect the health of US citizens. And it called for the establishment of a global infectious disease surveillance and response system based on regional hubs and linked by modern communications. Every 4 years, the US Intelligence Council publishes a global trends assessment that's designed to inform new administrators and policymakers about the key trends and uncertainties that will shape the strategic environment for the US over the coming decades. The 2021 report said that we lacked a full picture of the breadth and depth of COVID-19's disruptive potential. However, the assessment also concluded that the standardization of data sharing and collection and the development of new public-private partnerships will complement national and intergovernmental actions in future health crises, including early warning, treatment, and vaccine development. As an infectious disease ecologist and disease modeler, I believe that public-private partnerships are extremely important component in the development of actionable infectious disease intelligence systems. So you may be asking, what does infectious disease intelligence have to do with ecology? I think that, that Claudia outlined this very nicely. This is a photograph of some flying foxes, fruit bats from Australia, taken by one of my recent postdocs, Dr. Cecilia Sanchez, who was studying the ecology of these species and their potential to contribute to spillover. These are just iconic example of the conditions under which humans and human commensals come into contact with wildlife and have the opportunity to receive their parasites and pathogens through spillover. The other way in which infectious disease ecologists have something to contribute, I believe, is through our methodology. In ecology, we have the discipline of theoretical population biology, which goes back 70 years, nonlinear dynamical methods that are used to understand the dynamics of rapidly changing populations, including those populations that make up epidemics. 5 years ago, we founded at the University of Georgia the Center for the Ecology of Infectious Diseases. We now have close to 100 researchers in our center in 15 departments, schools, colleges, and external organizations. And we welcome participation by government, nonprofit, and private sector organizations. Our group has accrued greater than $4 million in grant funding from the National Science Foundation and other agencies just to understand the problem of spillover. And in the last 5 years, we've produced almost 600 publications related to the ecology of infectious diseases. One of our modes of operation is through 4 standing working groups, 2 of which are focused on methodology, one that seeks to develop new tools for disease forecasting, and a second that develops computer programs and software libraries for rapid mapping of infectious diseases. Then we have a standing group on the problem of spillover, seeking to develop content information as well as new theory, and another group that focuses on the behavior of animals and humans and the role of behavior in infectious disease transmission and spillover. During the COVID-19 pandemic, we stood up a temporary working group in order to provide situation awareness. This working group focused on a variety of problems at various scales, ranging from simply producing and serving data as needed by public health officials and others, models that could be used for short-term forecasting, other models that could be used for scenario analysis and decision support. We participated in a project with the CDC to measure the importation risk to the US over time. We've developed spatial spread models for understanding the spread of COVID-19 in Southeast Asia, the United States, and around the world. The point that I want to underscore is that the problem of disease intelligence is a pluralistic one. There is no one workflow, analysis pipeline, or model that can answer all of the questions that we have. We're in an early stage in developing the science of disease prediction, and for this reason, purpose-built tools are needed for almost all of the questions that we have in infectious disease intelligence. And these problems arise very often because of those larger drivers that Claudia alluded to: the ecosystem changes, the landscape modification, the economic and social changes, and the ways in which people interact with animals throughout the world have often changed. And this gives rise to new possibilities for the emergence of infectious diseases in human populations. As a result, the frequency of infectious disease spillover events and the human and economic harm that they create has changed the way that many of us look at the future. This slide is from the World Economic Forum's 2021 Global Risk Assessment Report that was published on January 19th. This slide is from the Global Risk Assessment Report published on January 19th. And as you can see, the 5 highest likelihood events in order of severity are extreme weather, climate action failure, human environmental damage, infectious diseases, and biodiversity loss. Now that we understand that the emergence of infectious diseases is in fact an ecological problem, we understand that all 5 of these events are in fact environmental problems at their core. In terms of highest impact, infectious diseases tops the list. It's also worth noting that the World Economic Forum's 2019 Global Risk Assessment report, infectious diseases were much further down the list related to likelihood and impact than they are now. It seems that we've learned something from COVID-19. So this leads me to the fundamental question that this webinar proposes. Can we use infectious disease intelligence to predict the next pandemic? My answer to this question is yes and no. No, we could not have predicted that the disease would have emerged from a particular group of beta coronaviruses in a particular location in Southeast Asia in a particular, on a particular day and month in 2019. We couldn't have predicted which species this spillover event would have arisen in. It's like predicting the path of a specific tornado. But even as we can't predict a specific path, we do also understand the weather conditions under which tornadoes arise. And we've built life-saving information systems around such knowledge. So also, I believe, yes, in a statistical sense, we can identify and understand the conditions that enable infectious diseases to spill over into human populations, and we can make similarly life-saving predictions. We have for decades been concerned about global pandemics of respiratory viruses. The 1918 flu pandemic has been well studied, and the fact of the matter is, we are hardly better off now than we were then in preventing such diseases from arising and spreading. Although the technologies to develop vaccines to keep people alive from novel viruses like SARS-CoV-2 have dramatically improved over the last 100 years, our ability to use technologies to prevent transmissions early in the process are the same. I was pleased to see that on his second day in office, President Biden announced an executive order for the formation in the US of an interagency center for disease prediction. And of course, the CDC is one of a number of global organizations that are developing such centers for disease forecasting and outbreak analytics. For me, the problem of prediction will require that we focus on moving forward, and in particular, the problem of data acquisition. I think that future developments in prediction need to focus on integrating data from a variety of different information systems that will need to monitor human and natural processes at a wide range of temporal and spatial scales. For illustration, we might think of the use of remotely sensed data on weather, the environment, and urbanization, factors that are related to things like the control of malaria and the spread of Rift Valley fever. But we also need information about people and animals and the conditions in which they engage in contact, from the village level in the rainforest to the urban center and throughout all places where humans and animals come into contact. We need to understand the movements and behavioral patterns of people and the ways that infectious diseases can move into urban centers and spread from here around the world. And of course, we need to think about in highly congested urban centers, New York, London, Beijing, Wuhan, Taipei, how people interact with their natural environments, their food sources, and how we all travel from one location to another. All of this is infectious disease intelligence language. To effectively monitor the circumstances that collectively increase the chances of infectious diseases emerging, I think we need to develop a Center for Infectious Disease Intelligence that is specifically staffed to study the conditions that lead to the rise and spread of infectious diseases. What have we been doing? I've already mentioned that I believe that any approach to infectious disease intelligence, modeling, and analytics must be pluralistic. In 2016, together with Barbara Hahn, I wrote a paper suggesting that we take our cue from a three-tiered system for thinking about emerging threats in weather: watch, warnings, and emergencies. A watch is about situation awareness before spillover occurs. Warning concerns a developing situation, and during an emergency phase, analytics can be used for decision support, to guide interventions, and to minimize damages. A watch system can escalate to a warning, which can then result in an emergency when the World Health Organization declares a public health emergency of international concern. The COVID-19 pandemic is the quintessential public health emergency of international concern. Other pandemics of international concern included the 2014 to 2016 Ebola pandemic, and the 2015 global Zika pandemic. I think that distinguishing these tiers is important for a number of reasons. One is messaging. Another is because the actions that we can take to prevent continued spread are different in each stage. As a scientist and a modeler, to me, what is interesting is actually that the data and analytic capabilities we have and require are different in each stage. One of the things that I am working on now with a number of my colleagues is a kind of conceptual framework to map these analytical capabilities to the three stages of infectious disease outbreak, and indeed to develop new analytical capabilities for problems that we have not yet solved. So here are some examples of analytic systems that we developed at the watch, warning, and emergency phases for a variety of infectious diseases. At the watch phase, we've begun developing a warning system for the spatiotemporal spillover risk of yellow fever in Brazil. In COVID-19, during the early phases, we developed models and comparative assessments to try and understand how SARS-CoV-2 might compare to other pandemics with which we were more familiar. And of course, as we moved into a phase of containment and damage control, we developed a number of models that could be used to guide decision-making at various levels. This three-tiered system arose from our early work during the 2014 to 2016 Ebola epidemic, where the task was different, but the tools were similar. And in real time, we developed models to answer questions about where spread was most likely, which interventions would be most effective, and how to optimally distribute resources, such as Ebola treatment units. But these, of course, are not the only kinds of analytics that one might develop. One of the things that we've been working on for the watch phase is statistical characteristics of disease emergence events and the pathogens and vectors that are associated with those emergence events. So for instance, a model using machine learning was able to identify from the network of associations between filoviruses and their mosquito vectors, the range of possible vectors of Zika virus before it was introduced to various habitats. In another set of projects, we're looking to characterize the functional biology of parasite generalism. Parasites do, in fact, range in promiscuity from those that are quite specialist and therefore unlikely to spill over into novel species, and those that readily make the species jump. And we believe that by characterizing the biology, the physiology, and the ecology that underlies this ability for species transition, we may identify those viruses that could emerge in the human population before they do. Related, we've been developing theories that seek to understand the ecology of disease emergence as low-dimensional dynamical systems. Such systems can be informed by data we have on the biology of the species in the wild environment and the way in which those species relate to one another. This particular model is parameterized with data on a wide range of traits of animal reservoirs and the conditions under which those reservoirs then have the ability to spread their pathogens to novel species. Another project looks at leading indicators of epidemic transitions. There are many diseases around the world which are endemic and at a low level. And we understand that slow changes in the environment or in the populations in which these diseases are spreading can result in supercritical conditions arising. About 10 years ago, we first reported on a theory suggesting that there should be key patterns in the data leading up to this point of criticality due to a phenomenon called critical slowing down. And in the 10 years since then, we've developed methods for estimating the level of critical slowing down from time series data. These are technologies that we hope in the future will lead to early warning systems for disease resurgence and reemergence. And then, of course, there's the environmental modeling and mapping that underlies the species, whether reservoirs or vectors, or the conditions that bring those species together and result in the occasion for spillover to occur. During COVID-19, we developed many such analytic capabilities. We shared these with our local partners at the county and state level. And we hope that our efforts in this direction were useful to decision support. But we're well aware that there's a lot of work that remains to be done for us to be able to actually link the capabilities of academics with the needs of decision makers and the action space that they have. To that end, our most recent development is a model called the Gaussian infection state space model with time dependence. This model respects the fact that underlying conditions such as human behavior may change, and that many, many covariates may inform on how those behaviors are changing over time. In the case of COVID-19, this was things like mask wearing or queue distancing. We believe that this is the first model that's able to run at scale in order to incorporate a wide range of covariates and include this semi-parametric responsiveness to the underlying changes in the environment during the course of an epidemic. And so this brings me to our latest initiative, the Global Infectious Disease Intelligence Consortium. Predicting and forecasting the next pandemic will require next generation tools capable of handling and evaluating multiple unknowns and providing actionable intelligence in near real time. In COVID-19, we developed new disease forecasting architecture that combines mechanistic transmission models with observations to account for imperfect reporting. Our key innovation was a mechanism for efficiently evaluating the predictive power of dozens of potential covariates and incorporating only the most relevant ones in time-varying ways. But we need to take these forecasting capabilities and modify and adapt them for the particular needs of different decision makers. I believe that disease forecasting is possible. It's also very important. Prior to COVID-19, concern about infectious diseases was primarily confined to academia, agencies like the CDC, the intelligence community, the Department of Defense, and the World Health Organization, and of course, every country's Ministry of Health and analogous organizations. But COVID-19 changed the strategic importance of being aware of emerging infectious diseases. I've had conversations with restaurateurs, hotel operators, hospitality trade organizations, and others who describe the sudden loss of revenue and having to lay off employees. In Atlanta, which is near to me and is the 10th largest economy in the US, the hospitality industry has not yet recovered. And of course, that's true in many, many parts of the world. I participated in webinars with companies in the consumer goods sector and learned how COVID-19 disrupted global manufacturing and distribution because of pandemic-specific employee absenteeism. This is evident now in supply chain disruption that we're all familiar with. One multinational consumer goods company told me that they need help developing models to understand how an approaching pandemic may limit employee availability. They want to develop strategic plans around an approaching infectious disease similar to how they work around severe storms. My point is, one of the things that I've learned is that the response to infectious diseases is not just a governmental, non-governmental, and academic enterprise, but one that involves all sectors of society. The list goes on and on. There's not been a collaboration between academia, government, industry, and other interested groups that specifically brings people together to discuss the challenges of infectious diseases across sectors. And so we launched GIDIC, the Global Infectious Disease Intelligence Consortium, to try and bridge this divide between academia and other sectors. Some of our early partners are Boehringer Ingelheim Animal Health and the Swine Health Information Center in the United States. GIDIC is specifically designed to listen to member needs and help them find solutions, and also to inform academics like myself about what the needs are for the development of new analytic capabilities in research and development. If you'd like to learn more about GIDIC, I'd be delighted to have a conversation with you. Thank you.
Thank you so much. That was an extremely insightful presentation. Thank you so much for coming. We're gonna go for a 5-minute break now. We'll be back at 5:15. See you soon. Sorry for the short break. I hope all of you had the chance to have a cup of tea or stretch your legs. We're gonna move on now to our next panelist, Dr. Madeleine Thompson, which is the head of climate impacts at Wellcome Trust, has over 25 years of research experience focused on large-scale climate-sensitive health interventions in low and middle-income countries. Thank you for coming today.
Well, thank you, and thank you very much for the invitation. I do have some slides, but first of all, I just say it's very nice to be later in a program and having had the chance to hear the previous speakers. And so I'll try as I go through my presentation to make some connections to the excellent presentations that we've had so far. So first of all, let me just make sure my slides can come up. I do very much recognize the extraordinary developments that have happened in the space of early warning systems. As David mentioned, I've been in this game for a little while. So the first thing I want to start off with is just saying that the idea of early warning systems for infectious disease is not really very new. Work was done in colonial India under the British Raj to predict malaria epidemics, and that followed a 1908 disastrous epidemic with over recorded 300,000 deaths at the time. And Christophers, who was in charge of malaria control from about 1910 through to the beginning of the Second World War, was very much involved. There was a huge amount of malaria research going on in India at the time, and they developed an early warning system which was based on an understanding of the economic conditions of the time, the absence of an epidemic in the previous 5 years, and the characteristics of the July to August rainfall. And basically what they were looking at is what was happening in society in terms of poverty and the economic situation. The importance of looking at the absence of epidemics in the last 5 years was basically as the population immunity low, and then high levels of rainfall in July, August was a key driver for epidemics. And that early warning system persisted for a long period of time, and epidemics of malaria occurred in India really until the British withdrew or were thrown out, and the Indians reorganized society in such a way that protected the economic conditions and the food security conditions of the population. And so following the departure of the British, they didn't really get these large scale epidemics of malaria anymore. So I just wanted to say the first thing is that epidemics are obviously not new, but also predicting epidemics is not new. And there's a considerable literature around the early warning systems set up in India. I'd like to mention the fact that over 20 years ago, myself and colleagues working with the World Health Organization and many other researchers focused on malaria, developed this document, which was a framework for malaria early warning systems. And we looked at 4, if you like, sources of information. The one on vulnerability of the population to epidemics. We introduced the concept of seasonal climate forecasts, which was a very new thing at the time. The ability to forecast the climate a season ahead really came out of the research that was done on El Nino in the 1980s and 1990s. And that, for the first time, we started incorporating that into the sort of a general framework for malaria early warning. Looking at weather and environmental information, which people were already familiar with, and then of course the importance of disease surveillance at the time. And we went into a lot of detail as to the various indicators, concept partners that could be used to develop an early warning system, but have found it extraordinarily difficult to deliver, I would say, on early warning systems over the years. And I want to share some of the challenges that we faced and a little bit of what is different today. So the first thing was having an early warning system that incorporated climate information was based on the assumption that, of course, you could access climate information in a useful way, particularly on the African continent, which was what we were concerned with. And at the following the work we did with WHO, I moved to the US, where I worked at the International Research Institute for Climate and Society. And there we were contracted by DFID to look at the climate observing system in Africa and the investments that would be needed to develop an observing system that could support the delivery of the Millennium Development Goals, which were the new big policy drivers that happened after 2000. And a lot of discussion, a lot of involvement with the health, agriculture, water resources, and climate community in Africa led us to the conclusion that just building more data wouldn't make a lot of difference, because there were so many gaps across the whole system. First, the gaps of integrating climate into policy. There was no structure to do that with. The gaps in integrating climate into practice. People have to have the capacity, if you like, to use information to make decisions. And that was not available. There were no climate services to speak of at the time that would be relevant for health. And services have to be produced on time in the right format and delivered through an appropriate dissemination mechanism. And there were huge gaps in the underlying data that was being made available. And so one of the conclusions of this report is that managing climate risk, and in the context that we're thinking malaria risk in Africa, was fundamentally a development issue rather than just a technical problem. And I think that was something that really came out from David's presentation earlier on. So there are, of course, many different aspects of health that relate to climate. I'm just going to focus on vector-borne diseases for the purpose of this talk, and just because I have done quite an extensive amount of work on malaria. But I do want to recognize that this does cut across many of the areas of work that we're discussing today, and thinking particularly about vector-borne diseases and their relationship to environment, which is inevitably complicated and nuanced depending upon the particular vectors that you're talking about and the particular environments that they're in. I just also want to say that when we look at the pathogens that they carry, there is a kind of exquisite relationship between the pathogen, its relationship to temperature, its relationship to environmental temperatures, which of course fluctuate enormously, and then its relationship to host temperatures, particularly in a human or animal host, which are very narrow. And you have a very complicated set of interactions, and sometimes the pathogens are unable to cross into a human host because the temperature at which they function best is not that that we support, or it's very easy, they can move swiftly into a human host because they actually function at the right temperatures that we have. So a lot of work that's been done on looking at the details of the interactions of temperature in particular and pathogens, and then of course broader environmental data and vectors or secondary hosts, as well as human hosts. And then of course the whole idea of an early warning system is based on the idea that there are lags between all of the different stages that we have in infectious disease, from the development of environmental conditions suitable for vectors to develop, for instance, the gametocyte carrier population, what's that status and what's driving that, could be migration, etc. Looking at the specific temperature ranges of the different pathogens and hosts, as I've mentioned, and then of course the susceptibility in people. And then you go through stages, and I've just put the example for malaria, where you have to think about the mosquito development, infection of mosquitoes, infections of humans, humans turning up sick in facilities, etc., and then being recorded as a case. And that will take weeks, if not months, to happen. And that's actually what provides the opportunity for early warning. And having engaged with this for quite a number of years, one of the biggest challenges that I personally faced was trying to understand, we can model things, we can collect data sets and create predictive models, and that's fine. But why is it so difficult to actually make them work in the real world? Where are the biggest sources of uncertainty, and what drives that actual uncertainty? And so this, what I'm presenting here, is the results of a paper that I undertook with Adrian Tompkins, and we looked at specifically 3 conditions and how uncertainty in being able to estimate those conditions created uncertainty in modeling. And we used as an example here malaria in the East African highlands at the Kericho tea estate as an example. And first of all, as a conceptual framework, you obviously need to start off like, what's the detail of the problem that you're actually focused on? And then there are quite a large number of models that integrate climate, vectors, pathogens, and human hosts. So you can look at the different models. And what I wanted to focus on in this study is that you do need to understand whether uncertainty is coming from these initial conditions, like you don't know the number of gametocyte carriers in the population. Therefore, how would you know how rapidly an epidemic is going to take off, for instance? Or if you don't know how well you are able to assess the temperature environment in which vectors, pathogens, etc., actually exist, how do you deal with that level of uncertainty? And then, of course, all of the model components themselves, the parameterization, is challenged at every point with our ability to understand and model correctly the various parameters. So in brief, you look at the boundary conditions with meteorological data. You have a meteorological station at one point, but obviously in the Western Highlands, you're in a highland area, temperature changes almost within a few yards. So how would you factor that in to your model? The initial conditions, as I've mentioned, extremely important to understand what the baseline infection rate is in a population, and then the complexity of understanding and developing models where, of course, you're only capturing an aspect of the details of the development of the pathogen within the vector and the human host. And then, of course, on top of that, you've got big problems in actually creating the data or accessing data that gives you a predictant that is closely related to actually what's really going on in the real world. So if you think we started out in 2000 to look at malaria early warning systems in Africa, and this paper came out in 2008, basically saying we are investing billions of dollars in malaria control through the Millennium Development Goals, and yet we don't have a proper surveillance system to even say whether or not we're having any effect. So if the surveillance system is not there, you can't create a proper predictant, and therefore your model has got nothing to test it against. And you can quite easily create models against very poor data that are predictive, if you like, but actually fairly meaningless because the data itself is not worth it. And this structure then goes on to look at, once you do have a validated system, how do scientists interpret those results versus decision makers? And that can be a very different thing. So as expected, from earlier work that we've been doing, the experiments that we did for this paper showed that initial condition uncertainty, that is, for instance, the number of infectious individuals in the population prior to an epidemic, doesn't really matter if you're running a long-term simulation in a model, but it does matter a lot if you're developing early warning systems. And also the spatial uncertainty of the temperature. In the highland regions, where temperature varies literally by at very small distances, is actually a huge source of uncertainty in model development. And we see that now. Then how do we get the type of temperature data that is refined enough to actually drive a model when that is the major source of uncertainty? Going back to this concept of vulnerability in malaria, we have historically understood it through classification, if you like, of three major malaria types. The one is the true epidemics. That's in a region where you normally don't get any malaria at all, or very little malaria, and suddenly, for some reason or other, you have a big spike in cases, and that's what we would call a true epidemic. In a lot of Africa, you get seasonal transmission, and that means every year following the rainy season, you will get some malaria, but some years are much worse than others. So where do you develop your early warning system? On the rare situation where you get once in a blue moon an epidemic, or to deal with a seasonal transmission, which becomes unusually severe. The third example is really connects this vulnerability to the transmission dynamics, is where you have breakdowns in control, population movement, a decline in the economy, a change in the lifestyle, etc., and malaria creeps up in the population, and then you get unusually severe years on top of that. And these three types of malaria epidemics changes what you can actually do with an early warning system. In some situations, if it's too close to a normal seasonal rise, it may not matter about creating an early warning system, because the response that you're going to undertake is no different from what you would do in a normal year. So effectively, what this means is that the response needs to drive the definition of the early warning system. If it's a really unusual situation, you need an unusual response. If it's close to a normal situation, you need a routine response. Back in 2006, working with the European Centre for Medium Range Weather Forecast, we developed the first operationally structured use of seasonal climate forecasts for malaria. And we did this in Southern Africa, in Botswana, because Botswana actually had a very good health data, and particularly for malaria. And relatively speaking, Botswana is a wealthy country in Southern Africa, and it had invested heavily in its health surveillance system, and the majority of people use the National Health Services for treatment. So a good solid data set. And what we were able to show, and you can see it in the graph on the left, is that rainfall using CMAP, which is the one of the rainfall products that the climate people used, when we had high malaria years, it was associated with heavy rainfall. And not only was it associated with heavy rainfall, the diameter seasonal climate forecast system could predict that heavy rainfall at the large regional scale in Southern Africa. Also, when we could see drought in the CMAP rainfall data, that was associated with lower than normal malaria, and that drought was predictable using seasonal climate forecasts. So back in 2006, we could develop these very large scale crude assessments of what was likely to happen with malaria based on these regional climate models. And then what's happened over time is just that we've become much more sophisticated in the quality of the data to localize the data in specific countries. And the project that I've been working with over quite a number of years was called ENACTS, Enhanced National Climate Services. And the task there was to engage with the national meteorological agencies in different African countries to enable them to organize their own data, integrate global climate products, and create effectively that best quality data that was available anywhere in the world would be available in their own country for their own decision makers. And the example I show you above is for Tanzania, where you can go and they could see where El Nino, the major shifts in the climate system, impacts Tanzania most significantly. And you can create these maps and various tools that can be used not only for malaria, but also for agriculture and for water resource management. And in fact, what you see is that the tools developed for health very much come out of the development community's focus on agriculture and early warning systems for drought and food insecurity. This slide basically shows you how weather and environmental information was first targeted for malaria after an epidemic in Wajir in Kenya. There was a huge deluge of rainfall in this semi-arid region, which was followed by a massive spike in malaria and a very large number of deaths, a catastrophic mortality of under 5s. in the region. And the use of weather and environmental information was kind of really built out on that period and on the use of El Nino. The other piece of information that has developed over the last 20 years is the disease surveillance. There really wasn't any well-functioning disease surveillance systems in most countries in Africa. I gave you the example of Botswana as an exception, but most countries did not have them, whereas now we have the district health information system in most African countries, and this provides routine assessment of a wide range of health outcomes for analysis by the Ministry of Health and at the district level, with the idea that it can inform decision making. And there's been a number of attempts, I wouldn't say necessarily that successful, but to integrate climate into the DHIS2 to have climate informed decision making. So what I want to get across in this is that there's been these various components of an early warning system have developed over time. And back in 2011, we had this big celebratory meeting in the UN Economic Commission offices in Africa to look at what had happened over the previous 10 years. And that seemed to be a launching pad for an integrated approach between the climate and the health services in Africa. But it has been incredibly slow. And there, I think, as David mentioned, there are lots of reasons for that, politically, economically, the different cultures of the different groups, but things are really changing. And I think, first of all, is to understand that from a policy perspective, what you think is important to policymakers is not necessarily what is driving them to use a particular information system. So here in Tanzania, with a meeting with the Rollback Malaria Executive in 2014 on early warning systems, their main interest was to realign malaria control with the Sustainable Development Goals, reduce their reputational risk problem of not being able to respond to epidemics when they happened, and then finally maximizing the impact of their control measures. And other areas that we've looked at, which I think have had the biggest impact in bringing early warning systems into mainstream for the malaria community, was just simply to show them that temperature and rainfall impacts the way they actually assess themselves the value of their malaria control interventions, and therefore the budgets that they put against them. Because we've shown in Eastern Africa a lot of malaria control, the decline in mortality and morbidity, some of that at least is associated with drought, and they have to factor that in if they're going to be honest about the impacts of their intervention, and also manage the risk that when the climate comes back and it gets wetter, that epidemics will not undermine the investments in malaria control in the future. So briefly today, we've obviously seen significant declines in malaria over the last 20 years, but those declines have stalled. COVID is in part responsible for that, and the changing budgets that have now moved to COVID. That creates a big risk for exactly this thing of the return of epidemics into African countries as declining investment, both at the international and at the national level. But what has changed over the last 20 years? Much better information and understanding of the dynamic nature of vulnerability of individuals, households, populations at risk, and we're able to map those and identify those much better. Seasonal forecasts have really moved out of the research agenda into the operational agenda. We have a much better quality weather and environmental information, especially when that's integrating both global and local products, and a much more systematic approach to national health information available at the national level. And there are many ways that we can now think about using climate information in decision making, and I'll send you to a book that describes this in a bit more detail. It's a book that I published with my colleague Simon Mason, a climate scientist. It is open access, so don't worry about the budget, but it really is, the idea there is that if we're going to engage with a climate informed information systems, then we need to understand something about the climate. And so that's a resource for you if you are interested. And then finally, I'd just like to mention I was at the COP26 conference with colleagues from the Wellcome Trust. And it's extraordinary, I would say, the shift in integration of climate and health that's happened just over the last few years. Currently, there is now a joint office between the World Meteorological Organization and the World Health Organization. We had over 60 events in what is called the Blue Zone, which is the official part of the COP process. And that was the first time that WHO had been there with their own pavilion, etc. And Wellcome was there supporting the global conference on climate change and health. And personally, I was particularly interested in moderating a panel on climate science and services for health adaptation, which really showed a lot more maturity in the systems and in the integration of these different communities, which has been so difficult to achieve. So I must say, I did feel that things are moving in the right direction. And of course, now we have also the fact that the health services themselves are committing to a low carbon health systems. We see that climate is integrating right across the health community. So I'd like to stop there and thank you for listening.
Thank you so much, Madeleine. It was extremely interesting to see the potentials and all the complexities and challenges involved in using climate data, especially in the context of the malaria disease. So now let's move on to our last panel presentation. We're running a bit short on time, but we're hoping to address your questions at the end. Let me introduce Dr. Jan Sementa, who is the head of Health Determinants Program at the ECDC and has led the work on environmental and climatic drivers of infectious diseases.
Thank you, Claudia. Thanks for inviting me to speak here. What a fantastic panel. I've learned a lot. I would like to address similar issues that we have discussed just now earlier. And the question is, can we monitor environmental and climatic precursors of disease in order to intervene early? And you all know that IPCC, the Intergovernmental Panel on Climate Change, they define climate change from different angles. They look at the hazards, and then they ask who's being exposed to these climatic hazards and what are the underlying vulnerabilities. And those are the ones that define the impacts and then, of course, also the risks in the future. But the question is, whether it is possible to intervene on these type of different levels, the hazard, exposure, and vulnerability, in order to predict potential epidemics ahead of time. So is it possible for us to monitor climatic suitability, as you can see in the bottom corner here? Can we monitor population mobility? And obviously there are lots of other things we can do to control potential outbreaks, such as vector control, avoid wildlife exposure and so on, and then intervening on the vulnerabilities. But basically the concept that we developed at the European Centers for Disease Prevention and Control is based on this kind of a framework where we look at climate change that leads to environmental consequences with direct exposures, indirect exposures like vector-borne diseases and socioeconomic impacts. And we in public health tend to monitor those health outcomes at the very end of this causal chain with our surveillance systems. And the question is, can we work upstream? Is it possible to monitor these environmental and climatic precursors of disease before they have an impact? And that's the system that we built at the ECDC, the European Environment and Epidemiology Network, where we're trying to monitor those impacts ahead of time. So this is the concept. You've all seen these epidemiologic curves these days during the COVID pandemic. And the question is it possible to monitor an environmental signal that could then potentially initiate active surveillance, where we could potentially pick up a first case, and then we could initiate the response. And with that kind of an early warning system, we might be able to suppress an epidemiologic curve like that and reduce the health impact. And when we evaluated all the infectious diseases in Europe that are climate sensitive, we ranked them according to this weighted risk assessment, according to the link with climate change and the potential severity impact on society. And we came up with this matrix here. And the one thing that we noticed was that in Europe, there is no surveillance system, no continent-wide surveillance system for marine bacteria like this Vibrio bacteria that are found in brackish water, water with low salt content, that can be very serious when it comes to infections. And so we decided to build this European Environment Epidemiology Network by merging epidemiologic intelligence data with environmental climatic data, integrate them, analyze them, interpret them in order to try to take public health decisions based on that kind of an analysis. And when we apply that to this Vibrio situation, you can see that a lot of people go to the beach during the summer months at the Baltic, where they get potentially exposed to this marine bacteria. And the bad news is that they can be very serious because the wound infections have a 25% mortality rate. They can cause gastroenteritis and septicemia with a 50% case fatality rate. So those are very dangerous infections, and something needs to be done about it. And it turns out that these bacteria, they thrive in marine environments when the sea surface temperature surpasses 15 degrees. So there's a very strong climatic link with these type of infections and the sea surface temperature in the Baltic. And so we built the Vibrio Map Viewer at the European CDC, where we monitor in real time with remote sensing these environmental suitable conditions for Vibrio growth by monitoring sea surface temperature and sea surface salinity in the coastal areas around the Baltic with satellites that that provide these data free of charge. And then we make the data available through the Vibrio Map Viewer, illustrated here on the top right, through the E3 Geoportal at ECDC. And this is what it looks like. This one here gives us 5-day forecast. So this is a 5-day forecast early warning system that monitors the sea surface temperature in the Baltic. It actually works worldwide, but this is here towards the Baltic. And you can see that in 2014, we picked up an environmental signal that indicated an increased risk for these Vibrio infections. And sure enough, that's exactly what we detected in the surveillance data that Sweden collects. As I mentioned, these data are not available anywhere else, but Swedes do collect those type of data. And we built a case crossover study and saw a very strong exposure response relationship with these kind of environmental signals. So if the sea surface temperature goes up, we see an increase in risk for these type of infections. So we know that this tool is working. It's up and running at ECDC. Every summer months, we monitor the sea surface temperature salinity in the Baltic, and we provide reports in the CDTR, the Communicable Disease Threat Report, that's then sent out to all the state epidemiologists around the Baltics to alert them about the potential risk in a bay that needs to be shut down. But as I mentioned, we are interested in monitoring these different type of aspects of climate change, hazard, exposure, and vulnerability. And I just showed you a model that we have built for the sea surface temperature salinity in the Baltic by monitor climatic suitability. But is it possible to monitor population movement, population mobility as potential risk and indicator for vector-borne diseases? And this is exactly what we built here. It turns out that there was a tropical disease outbreak in 2017 in the southern part of France and in Italy of a disease that's called chikungunya. It's transmitted by the Asian tiger mosquito, or the Aedes albopictus, that's present in the southern part of Europe, illustrated on the left panel here, illustrated in yellow. And it turns out that in 2017, there was an outbreak of this chikungunya disease in the southern part of France, in the Var district, in the southern part of France and in Rome. And we mapped out the passenger volume of individuals that come from chikungunya endemic areas worldwide into Europe. And you can see that these two areas highlighted with these circles were in fact in very close proximity to those airports that bring passengers from abroad into Europe. And when we then computed the climatic suitability or the vectorial capacity in this case for Aedes albopictus, you can see that July and August were exactly the months when we observed that outbreak that were climatically suitable for transmission. We then took this to a next step where we used Twitter feeds from individuals within the epicenter of those two outbreaks of chikungunya, and we monitored them forward in time. So once an individual tweets at the epicenter of the epidemic, where do they go next? And we were able to connect the outbreaks, the local outbreaks, and the dispersion of the disease with this kind of Twitter feeds. So we're using Twitter feeds as a proxy for population movement, and can then map that to the outbreak situation illustrated on the left panel here, where you can see that the Var district is connected with these Twitter feeds with Rome, and then in fact further also it spread into Calabria, that we were able to map out with this kind of an approach as well. We can then, of course, take this kind of a risk map and model that forward in time by using climate data. And we saw that certain areas in Italy are at increased risk for chikungunya, as opposed to other ones where we see a contraction of the risk when it becomes too warm and dry for transmission. So this is an example of an early warning system for vector-borne diseases that can be used by using population movement and climatic suitability for vector-borne diseases. And what we do here is that we monitor population movement, we monitor the importation risk of viremic individuals into Europe, then we monitor the climatic suitability, we can then intervene by eliminating vector breeding grounds and set up seasonal surveillance to pick up a potential case. We can then assess the exposure, set up vector control measures to detect the first case, verify the case, notify, and then intervene in order again to suppress the epidemiologic curve of an outbreak like that. So in summary, we believe that we can use these kind of data sets to set up early warning systems, but the most important thing is to engage the community in these type of early warning systems, because without community engagement, there will be no response and no impact of these early warning systems. And there are in fact ways to engage communities by enhancing social networks through bonding social capital, and also bridging social capitals by connecting people with government agencies, and engage the community in decision-making and the preparedness and response efforts, and then intervene on the hazard exposure and vulnerability, as I mentioned earlier, in order to have a bigger impact within communities. And so this is an approach that I call lateral public health, which is an integral part of these early warning systems if you want to have an impact. And I can elaborate on how to do that in more details, but these are systems that are up and running, this is a way where we can enhance communities and engage them in these type of early warning systems for the benefit of public health. So in conclusion, we can use big data for public health purposes, and we believe that this can lead to a paradigm shift away from these lagged responses that we have seen, particularly during the COVID pandemic, towards a more active, targeted, strategic approach to predict and prevent these type of pandemics. But an integral part of these early warning systems is, in fact, to have an engaged community, and we need to use these principles of lateral public health, as I call them, to have an impact to make these early warning systems operational. And here are the individuals that conducted the work, and particularly Joachim Rockle from Umeå University and Elizabeth Lindgren. And here is my email for any questions that you might have. And thank you. So I'll stop sharing here.
Thank you so much. I'm just fascinated by the work of the European Environment and Epidemiology Network. I really believe it's pushing forward for more holistic and anticipatory warning systems. So we're going to move to the Q&A finally, a bit late, but we're here. So the first question I want to flag, which I think is a great question, which was by James Evendine, is that I want all of you to just briefly say one thing about it, is how do you think we can change the culture towards warning systems within governments and organizations and support the research into drivers and surveillance? SARS-CoV-2 has obviously rewritten the rule book for costs to the global economy, but what other ways can we facilitate these interdisciplinary initiatives? Okay, let me first start about Dr. Madeleine Thompson.
So I think the first, I think, is that early warning needs to be tied to response. So what part of the community, if you like, has said, let's call it the development of early response. Then the early warning system sits under the response. So understanding what people will do with the information, how they will change something, I think is key to building the early warning system that people can use. So I think that's one thing. The other thing is the community that really knows how to use early warning in many ways is the impact, the insurance community. They want to understand the different drivers of outcomes. And so understanding how they use early warning and building an understanding of risk and risk assessment, because we're never able to precisely say what's going to happen. It's always a matter of saying that we think the risks are changing, the risks are increasing, the risks are decreasing, and we have to build the language of risk, if you like, into the way we develop our response and therefore the early warning system itself. So I think, you know, as was shown early on, I think it was in John's presentation with the World Economic Forum looking at global risks. Yeah, risks aren't a prediction per se of saying this is exactly what's going to happen, but just creating an environment of awareness, which is what the private sector uses to understand how it should organize itself, how it should build resilience, etc. So I think moving towards a language of risk and understanding how society understands risk and response is a place to go.
I think that's a key component of differentiating between risk and uncertainty and other variables. Let me now move on to Dr. Don Drake.
So my answer is we need to quantify performance. How good are our warnings? And if we can quantify performance and relate them to actions, then I think we can show what their value is. Until we do that last mile of demonstrating value, I don't think there will be much uptake.
I agree. We need to incentivize investment, and that requires showcasing results. Please, Dr. Dan Smith.
Yeah, well, the thing that I like to stress is the community engagement. That example that I usually bring is there was a massive flooding in Nepal in 2006, and there were two communities on these different branches of the river, and one community was very much engaged in the preparedness activities where they dedicated an individual to read the gauge reader for the river, and then how to trigger an alert, how to give the warning signals, and how to engage the community in the response, whereas the other community didn't really track, and they were not that interested in that kind of initiative. And then when the flood hit, the community that was engaged in the early warning system, they were able to move their assets and their houses, or not the houses, the movable assets out of harm's way, and they were able to save many more lives compared to the community that didn't engage. So ultimately, it is about engaged communities and working with them in the decision-making process to set up these systems. Because if we detach the work that we do from communities, we won't go anywhere.
I completely agree. We're actually aiming within the UCL Warning Center to have the next webinar on integrating communities and community-based engagement, because those are like the information that we have about them is way less prevalent than at the international level. So it's great. Okay, given that we have very short time, let me end with one question, which is, if you could put forward one thought about the next pandemic treaty or the reform of the international health regulations, what could that be? If you could put forward one thing. Not an easy question, but can you go first, Madeleine? Thank you.
Well, I think that it builds on what Han has just said about engaging society, because we've seen that technology is not enough. We've seen that with COVID in particular, where both the UK and the US topped the joint JEE, the joint evaluation exercise of the global health security agenda. So we have all the technology, we have the capability, we have the institutions that can monitor things, etc. But huge challenges in terms of the early response And now that we have vaccines, the technological societies, if you like, have an advantage. But if the populations aren't accepting the vaccines or don't trust the government, don't trust science, etc., then all of that technology kind of goes to naught. So you have to build trust in the community, and that is only through engaging with people. And so I think that very broad societal trust and active engagement has to happen before you have an emergency situation.
Yeah, so I'm talking here about the pandemic tree, but maybe we should be talking about bottom-up approaches, no? For sure. Okay, Dr. John Drake, go on, please.
As all three presentations made clear, data is key. And my observation is that data protectionism is still rampant. So whether it's organizations, governments, or individuals, people have various reasons for preventing data from being shared. And that comes at a cost to all of us. So I think just as we collaborate on response to infectious diseases and pandemics in particular, so also there need to be mechanisms that ensure that data are shared widely.
Really agree.
Yeah, so I mean, the international health regulation with the core capacities in public health, they have been assessed worldwide, and all these countries ranked really well with the Global Health Security Index, particularly the UK and the US. They maxed out with the index, and this index was published 1 month before COVID hit. And then you saw which countries were affected the worst. It was in fact exactly the US and the UK. So it's not just having these excellent systems up and running, it's also about leadership. How do we capture corrupt governments that are unwilling to act on data, right? I mean, that's the index that we need, because ultimately that's where it's at. Because if we don't have the leadership from the top, the community is at loss too. So we need to have this working relationship between governments and communities. Otherwise, it just doesn't work. So if you can develop a corruption index or a transparency index that captures some of that, it's essential, because what the tools that we currently have don't capture where we are.
Thank you. Well, we're running out of time. I'm sorry we have not been able to answer all the questions. I do hope you have enjoyed the presentations. Again, I want to thank all the panelists. It's been amazing to be a part of this webinar. I've enjoyed it personally so much, and I hope we can keep on collaborating in the future, maybe in the next webinar, who knows. Thank you so much, and I hope you enjoy the rest of your evening.
Thank you.
Goodbye.
Bye.
Thank you so much.